People do. Can you? Yep. So if you do that. This is where it's supposed to be? Okay.
All right. Hi, how you doing? It's almost lunch. Yay. My name is Brantley, so you probably saw me here this morning. If you didn't, don't shake your head no, because then we know you were late. All right, and I know I am between you and lunch, so we will go through this and try to make it as interesting as possible. If you have any questions, of course, please feel free to raise your hand and ask as we go. My part of this is to talk about how inclusive planning directly impacts you at your organization or facility level. I do regional inclusive planning for all of the localities here in the Hampton Roads region. And then prior to that, I did it as an emergency manager for the city of Anchorage, Alaska. So incidentally, we had a warmer winter than we did. So that's it. Okay. All right, so what is inclusive planning? How does it affect continuity at your organization? It means not only making sure that your clients or your patients are included in your emergency continuity plan, but also your staff as well. That's the part that a lot of people forget. So a lot of you have staff in your organization who have a health or medical or disability needs, and that needs to be incorporated into your continuity plan as well as your patients or residents. Continuity planning is also called HOEPS, Emergency Preparedness Plan. We kind of change our dialect there, our term. So, are you required to plan inclusively? And that's a very good question. How many of you guys are familiar with Title II and Title III of the ADA? Yeah, most of you. So, do you serve individuals with disabilities, including staff, medical needs, or limited English proficiency? So, anyone who speaks a language other than English and does not speak English well. If you're bilingual, fluently bilingual, that does not include you. Do any of your staff have any of those needs? And does your facility organization receive federal funding? So if you are a Medicaid, Medicare facility, you absolutely have to meet ADA requirements. And if you are considered a public use facility under Title III, ADA applies. And outside of ADA, it's the right thing to do. So additional requirements for inclusive planning. So what does this do for you in addition to, you've got to do your continuity plan, you've got to plan for your staff, but specifically, what are those requirements? You need to make sure that even in a disaster, you have as barrier-free environment as possible. So obviously, if there's been an earthquake and there's damage to your facility, things are knocked over, you need to do what you can to make sure that your escape routes are barrier-free. Again, if it's a disaster, you do as much as you possibly can because it will impede evacuation. You need to make sure your communication is effective, that you've included everything you know of with limited English proficiency. You must do advanced planning because on the spot, ad hoc stuff is just not enough, not adequate. But you will have to do some things last minute. If you're evacuated and all of a sudden an exit becomes inaccessible, there's some on-the-spot maneuvering that you have to do, and you're going to have to take into account those individuals with disabilities. There are specific ADA standards for fire alarms, accessible exits, signs, areas of refuge, and evacuation elevators as well. I can read those to you, but if you're this close to lunch, you might not like it. The reason that we talk about inclusive planning is, how many of you guys serve anyone with a medical need or a disability? Go ahead and raise your hand. That's pretty much all of you. If you work in healthcare, you serve vulnerable populations with special needs. And when you have something simple, not simple, if you have catastrophic level events, Hurricane Katrina, Hurricane Sandy, but those are not your most likely. In emergency management, we look at what's the most likely scenario and what's the worst case, because those are frequently not the same thing. How many of you guys have experienced a flood in Hampton Roads? Shouldn't be everybody. Okay, enough time. That's not questions, so I won't make you guys listen to it. But this is a great video about a long-term care facility that had done a continuity plan. And here's one of the keys. They had worked with their local emergency management agency to not just evaluate the plan, but they were coordinating, collaborating with emergency management from the get-go. They went and said, hey, we need to develop this continuity emergency preparedness plan, and we're not really sure what to expect from you as a city. We want to make sure that it's effective, and the emergency managers kind of guided them on their preparedness planning, their continuity planning. And then they trained and they exercised, they trained all of their staff, and lo and behold, they get flooded. And they got all of their patients out before the water ever reached their long-term care facility, because they enacted their plan that took them with an evacuation order issued. The city was already aware of who their clients were in general, what kind of support they would need, and they were aware of the location of the facility, what their preparedness plan was, where they were planning to go, how they were planning to get there. So they were better able to support that facility when it did come time to evacuate. And here's the kicker. Emergency management does not know about your patient and your client. Who does? Absolutely, you guys. You work with them every day. You know what their needs are. You know who in your facility or which one of your patients or your clients has a service animal, who has low or no vision, who needs an interpreter and for what language. So who is best able to advise responders or to plan for and prepare for the needs of the people in your facility or in your organization? That's you. Absolutely. So these are some pictures. Some of the things that you need to think about when you're doing your continuity planning. Transportation. How many of you guys know paratransit is going to be an issue? Absolutely. One of the things that we hear every year at HOEPS is that private paratransit is not willing to enter into contracts because there are so many facilities and organizations that need access. They're not willing to contract with just one person. Medical equipment and supplies. When you get to a shelter, in this region, there are what we call SFUs, shelter support units, that have up to 50 beds to support either an integrated general shelter or a medical shelter, depending on your locality. But outside that, it's going to be pretty critical for you to know what kind of medical equipment needs you have, both durable medical and consumable medical supplies. And at a minimum, have a list of those. Who needs what, and then a master list for any shelter managers so that you can start helping them coordinate to meet those needs. Because again, who knows what they are in advance? You or the disaster shelter manager? It's you guys. So know who to notify and where you're going to go. If you can take, I'm from Alaska, and we had in Anchorage the largest long-term care facility in the state, had almost 600 residents, from independent assisted living to skilled nursing care. It was a 5-story building set about 500 feet off of the Cook Inlet, which is like a big bay. They had a huge generator that was in the basement, and then they had the pharmacy was also in the basement as well. And when we started working with them in Anchorage, their plan was to get everyone out of the building and walk them across the street and wait for the city to come and pick them up. And that was the extent of their plan. How many of you think that sounds reasonable? No. So you need to know who in the city to notify, what's reasonable. If you're going to evacuate 600 people, talk to your emergency manager about whether or not they'd like you to bring all 600 to their shelter. Because you may need to make some other plans, put those plans in the agreement place. Personal care services. In a shelter environment, personal care services are required to help people meet their daily living needs. And so, personal care and nursing, are you going to, when you evacuate a facility, are you going to continue to provide care for your patients and your clients, or not? If you are planning to continue that care, and I understand there are issues about payment, whether for home health, if you're receiving care outside your home, then Medicaid does not pay it. Things like that. But at a shelter and in a disaster environment, you need to consider your staff and your staff's family. And if they're home taking care of their families, will they be available to take care of your residents or clients? And then work out with emergency manager. If you're going to open up a shelter and you're planning to bring your clients and residents to that shelter, are you going to be able to provide some staffing support? Because it will be necessary. And then sharing information. How many of you guys have heard HIPAA? Yeah, HIPAA. So, did you know that you can share protected health information with first responders in a life safety, when there's a life safety? That means if you're doing an evacuation and there's a life safety issue, you can share that protected health information without that individual's authorization. You need to plan for how are you going to get these individuals back home. You've evacuated, you've maybe dispersed your clients and residents to multiple facilities. Maybe some of them have gone to a disaster shelter or gone home to stay with family. How are you going to communicate your facility is back up and running? How are you going to get them back to your facility and get your staff back in place as well? Patient and resident tracking, that's always a fun thing to deal with. But how are you going to know where everyone goes, particularly for larger facilities? If you have to evacuate, again, when Alaska had 564 residents, they're not all going to the same facility. So you need to plan on how you're going to track who's going where and how you're going to get them all back. So outside of your facility, you guys can help too. Most of the events that we experience in Hampton Roads are very local. So there'll be certain areas of Norfolk or Potosin or Chesapeake is flooding, and there may be one or two care facilities in that area or a hospital. And how many of you guys have your own paratransit vehicle? Let's put this in Norfolk, and we evacuate 2 or 3 long-term care facilities. If you're outside Norfolk and have paratransit vehicle, will you raise your hand? 1, 2. Would it be reasonable if they just need help for a couple of hours evacuating to be able to call on you and say, hey, can we borrow your bus for a little while? Because not everything affects the entire region. Personal care, if you have staff who are willing to volunteer and go assist in a shelter that's not impacting your facility, I can tell you that would be very helpful. Coordination with other facilities and nursing staff. The number one issue for medical shelters in this region is staff, and you guys have quite a bit. And so if we can find a way to get you guys involved in helping support those facilities, support their shelter needs in your jurisdiction, it would be a kind of huge boon to provide the sheltering. So real quickly, in 2010, ADA was revised. I just kind of wanted to go over some of the things that are common that people know, the old regulations versus the new. Service animals are dogs only. Miniature horses were added to ADA, but they are not defined as service animals. And the reason they do that is because if it is a service animal, you are obligated, no matter what, to make room and accommodate that animal. The way they have it, they did a special kind of wording so that miniature horses can be used in some cases when it is reasonable and feasible for you to accommodate them within the facility. And then they outline very clearly when you can say no and when you can't. Dogs that provide emotional support only are not service animals, as opposed to if you have a resident or a patient or a client with PTSD, and that person has a dog who is specifically trained to assist with their anxiety levels, that is a service dog. If you have someone who has seizures and they have a dog who is trained to alert them to an oncoming seizure, that is a service animal. A dog is trained to remind people of medication, service animal. A dog who's there to make you feel good, not a service animal. So it has to be trained for a task specifically related to their disability, and it's a service animal. Yes?
But you can't ask the person what their service animal is.
You can ask them what they're trained, what task they're trained to do. So here's what we did. Service animals always get questions, so I brought the word for it. Okay. Staff cannot ask about a person's disability, require medical documentation, require special identification card or training documentation for the dog, or ask that the dog demonstrate its ability to perform the work or task. Staff may ask 2 questions. Is the dog a service animal? Is the dog a service animal required because of a disability? What work or task has the dog been trained to perform? So if you ask those 2 questions, first one you ask because of a disability, what task? Well, it keeps me calm and makes me feel good. So it kind of leaves a gray area because you cannot ask about a disability. You can't say, well, what is your disability and how does that relate? You can't do that inclusively. So a lot of times it's going to be a judgment call. Because especially with people who have service animals that are related to mental or emotional disabilities, it can be difficult. So if they have no answer for the task, then that's a clue you can pick up. So non-traditional mobility devices are now included after 2011 when this went into effect. So like Segways and the different types of power devices that people have now in addition to wheelchairs are included. And it specifically outlines the use of VRI, the video relay, and the training that needs to be provided to the active VRI. And then have you guys read the CMS proposed rule for Medicaid and Medicare providers? We gave you a handout that gives you an overview, but the 4 major provisions include risk assessment and planning, policies and procedures, communications plan, training and testing. So with the risk assessment, you're required to provide a risk assessment to determine what the risks are for your particular facility. Using an all-hazards approach, meaning what are all of our hazards and how can we plan effectively to meet those. And then update emergency plans at least annually. I mean, if you don't create an emergency plan, you don't pick it up for 10 years. You look at it every year and you revise it. And I should say way too far on this. This is a proposed rule from CMS. It has undergone a public review and comment period, and it's upcoming legislation, but it looks like very likely to pass. Policies and procedures. It specifies that you have to develop the policies and procedures according to a risk assessment. That's the whole purpose behind those risk assessments. They must address a range of issues, including distance. So how are you going to feed people who are sheltering in place? How are you going to do evacuation? How are you going to track patients? Those things we talked about a little bit earlier now have to be, or not now, are very likely to have to be included in your plan. Review and update policies and procedures annually. And then a communication plan. You have to provide a communication plan that complies with all your federal regulations. This includes limited English proficiency, low, no vision, and hard of hearing as well. You have to coordinate patient care with the facility, across healthcare providers, and with state and local public health departments and emergency management systems. So you're not going to be allowed to plan in a silo, as we call it. You have to collaborate and connect with people outside your facility. And an absolutely fabulous way to do that is the Eastern Virginia Healthcare Coalition. And so you'll hear a little bit more about that throughout the day, but they help coordinate and help collaboratively plan within the region for all healthcare organizations. Emergency and standby power systems, and then listening to the public reviews and comments. This has been kind of the key themes that people have looked at and gone, oh my gosh, those are pretty, those could cost quite a bit, but you are required to have standby power systems that specify additional requirements for long-term care facilities. And that's regardless of how small you are, you have to have backup power. Locate generators in accordance with the NFPA guidelines, conduct generator testing, and I believe this is annual. So you have to actually test your generators. You have to run them for more than 30 minutes. I believe it's 2 to 3 hours in the new legislation. And you have to maintain sufficient fuel, which is fairly common sense, right? So you have to have enough fuel to run your generator for several days. And then training. A plan is only as good as your practice. How many of you guys have a fire escape plan for your house? A little bit. Raise your hand so I can feel that. Alright, how many of you practice it once a year? 2 out of everybody who raised their hand. How many of you write the fire escape plan, talk about it one time, and never look at it again? Yeah. So for those of you who have kids, guess how effective that is? Not at all. It's the same thing with our plans in emergency preparedness. If you don't practice your plan, nobody's going to know what to do. How many of you guys have turnover at work? Absolutely. If you're not practicing and training, then your new staff don't even know that there is an emergency preparedness plan. So that's why they put this in. You need to conduct drills, you need to train, you need to exercise the emergency plan on an annual basis if possible. Home health agencies and hospices are required to inform officials of patients in need of evacuation. Again, it goes back to connect with your emergency managers because they don't know what your needs are in advance unless you tell them. Long-term care and psychiatric residential treatment facilities must share information from the emergency plan with residents and family members or representatives. So you can't keep your plan secret. You have to let the family members and residents know so they know what to expect. Any questions on EMS? It's all really excited about it. I have to say, from an emergency management standpoint, it makes sense. I mean, when you look at things that have happened over the last 5 or 10 years, and the level of emergency preparedness planning I've seen in long-term care facilities and other places, I think this has been a long time coming. From a facility perspective, especially smaller facilities, this is a lot of requirement on it. But please be encouraged that every jurisdiction in Hampton Roads has a group of people who can help you. Do you know what they're called? Your emergency management agency. So they're already required to review your emergency preparedness plan. You don't just have to engage them at the end, engage them all the way through. Because they're the experts on disaster response and emergency management. You're the experts on your facility and your needs. And so bringing the 2 of those together are how you're going to make this successful. Any questions in general for me? Okay. So before I let you guys get prize drawings for you. So we're training you and feeding you and giving you stuff for coming. I just wanted to give you information about lunch. Lunch tables are all have little table tents that have city names on them. So please sit at the table where you work so that you can connect with other facilities and organizations in your region and also your emergency manager if they are here. Lunch will be served down in ballroom E and F, and it will be a plate of lunch. If you have an allergy of any kind,